Hello, and congratulations on getting into medical school. Today's presentation will concentrate on the rotation in the Department of Radiation Oncology with a focus on medical dosimetry and the treatment planning process. Topics for discussion will include a radiation oncology workflow overview, the dosimetrist role in the department, some of the basic planning concepts, and some plan review. Radiation oncologists will have a consultation with the patient about recommended treatment techniques prescribed for their cancer diagnosis. Once the patient agrees to receive the treatment, assigned consent is completed and the planning process can begin. Important data is collected to assist with the planning. For example, has the patient had prior radiation treatment? Are they pregnant? Do they rely on a pacemaker? Are additional images available the physician will need at the time of contouring? This white sheet is a document that we use in the department to sort of answer those questions and document the response. The patient then is, once the consent is signed, they will then return for a simulation appointment. The patient is positioned in a stable, reproducible position on the treatment table in the sim room. Positioning devices are fabricated and well documented so that when the patient returns for treatment, the position that they're in can be accurately reproduced on the daily basis for their treatment. The CT scan is done after positioning the patient, and then the next appointment the patient will have within the department is when they start their treatment course. Usually it's about less than 2 weeks. So we average, a sim would be maybe around 7 days between the simulation and the first treatment appointment. After the simulation appointment, then the CTs are imported to the planning computer in dosimetry. There's images that might need to be fused to that CT if the radiation oncologist has requested them. Contouring of normal structures and anatomy relevant to the treatment area are done at this time. Then the radiation plans are generated. The radiation oncologist will do a thorough plan review. The plan will then be printed, and then physics will be notified that it is ready for a QA check. So the medical physicist, once the plan is ready for QA, they do testing to make sure that it is safe to be used as a treatment technique on the patient when they come in for their treatment. Radiation oncology physicists ensure the treatment machine delivers the correct amount of radiation during a patient's treatment. They perform quality checks on all equipment within the radiation therapy department. After physics has approved the treatment plan, the radiation therapists, these are the individuals who actually will be treating the patient, they perform another plan check before the patient is brought into the treatment room. There's usually, again, less than about a 2-week period following the stimulation before the patient returns to receive their first radiation treatment. The patient is positioned on the treatment table in the exact same position that they were at the time of the simulation. The fabrication of all of the positioning devices that were done at the simulation are all then brought in and used when we treat the patient for their daily appointments. At this time, treatment images are taken and checked by the radiation oncologist before the first treatment is actually delivered. After the treatment is given, the radiation therapist will then establish subsequent appointments for the patient until their course of treatment is over. And a course of treatment can be as short as 1 fraction or even up to 7 weeks. So it varies significantly depending upon their type of diagnosis. Following the course of radiation therapy treatment, the patient will then continue ongoing follow-up appointments with the radiation oncologist. These appointments are generally 6 weeks out, 3 months, 6 months, and annually or as needed. So now I'm going to focus more specifically just on the medical dosimetry component of the radiation therapy department. This is where the treatment planning process all happens. So after the CT simulation, the dosimetrist will import the CT images into the treatment planning computer in Dosimetry. They'll discuss with the radiation oncologist any additional imaging if physician would like that, such as like an MRI, PET scan, or a CT scan. Those images then will be fused to the planning CT. Not all cases require extra imaging, but in the ones that do, it's usually quite helpful to help the physician visualize the tumor extent or just the tumor volume and the extent of disease. So they are better able then to delineate the target volume. Dosimetrists will complete contouring of normal structures within the defined area that we're treating. They are not allowed to do any of the contouring of the target volumes. That is reserved for the radiation oncologist. Once normal contouring of structures is complete, the radiation oncologist will be notified and they can begin contouring the normal target volumes. So the image above demonstrates a typical kind of pelvis treatment or pelvis contours. So we've got the femoral heads, and then we'll have the bladder in yellow, the rectum is in green, and the prostate in this case would be in orange. So those are general and very common ones that we'll use when we do prostate cancer treatments. We'll contour in those structures. The radiation oncologist will complete target contours and double check the normal contours that the dosimetrist has done. And then they will give us their intent of their intended kind of treatment prescription. So here you can see on the screen, this is a sample prescription for a head and neck cancer patient. So in this case, and it's very common, there's different dose target levels that we're going to be trying to cover within that volume. So in this particular case, the high dose region is going to go to 70 gray. There's going to be a mid-range of the high risk nodal volume that'll get a dose of 63 gray, and then the lower dose risk is going to get to, the lower risk nodal volume will get to 56 gray. So these are more complex cases, but they happen a lot because we do treat a lot of head and neck cancers. So in addition to the treatment prescriptions, there are often additional planning goals that we strive for. These are often the dose constraints to structures that are near or overlapping with targets. The term given to these structures are called the OARs, or the organs at risk. These cases can really challenge the planning process. In the slide that you see here, there's a list of dose constraints based on the previous slide of the head and neck prescription case. So you can see there's the core dose, the brainstem, the parotids, mandible, hyoid, all the structures that are going to be within the pathway of the beam in order to treat the target tumors. So we do have constraints that we want to give those other organs so that they can, still hopefully maintain their function. So once all the contouring is approved, the actual treatment planning can then begin. The main goal in treatment planning is to deliver the prescribed dose of treatment to the target and spare the normal tissue as best as possible. With that goal in mind, the dosimetrist will need to decide on the treatment technique that they're going to start with. Is it going to be complex? Is it going to be pretty basic? We need wedges, those kinds of things are sort of thought thought out at the beginning, how the beams should be arranged and delivered, what beam energies would be best based on the location of the target and the dose limiting structures, and how can we design the best plan and still keep the actual treatment time within a reasonable duration. Because it is a patient that we're treating who is on a table, and we want to keep it as fast as we can without and still maintain a good quality treatment plan. So beam arrangement is important to begin the planning process, like I stated. In this example on the left, you can see what a beam profile would look like if it was on an anterior directed from the anterior aspect of the patient. So the red is just going to be where the highest amount of radiation is deposited. And then as that beam disperses through the patient, the dose of radiation is going to diminish. But if we were treating, in this case, the patient's prostate, the high dose would not be in that region. It would be, as demonstrated, anterior to that, which would not be an ideal situation at all. In the case to the right, we've opposed the beam. So now we have an anterior and a posterior beam. And you can see how the dose distribution is pretty thorough throughout that volume. Not that either of these would be ideal, but the one on the right would be better than the one on the left. So to improve on it, you would add more beams, and the dose distribution will concentrate in the area where the beams overlap through the divergence. So the area in red now is more centralized over, say in this case, the prostate, which would be much improved over the last two images that we looked at. So the three-field beam arrangement, that's an anterior and two posterior oblique fields. And then on the right-hand side, there's a four-field technique. So it's an APPA and right and left lateral. You can also see that the shape of the red area changes depending upon the beam's orientation to the patient. So at some point, the number of beams can become too many. The length of time that it would take to treat would also challenge the patient's ability to hold still on the treatment machine. So we have to keep that in mind. So the 8-beam arrangement might look really pretty, but in reality, it would be a lengthier treatment to deliver for the patient. So one other way to work around that is the image on the right is a dynamic beam arrangement where the gantry, which is the machine, it rotates around the patient as the patient, lays in their treatment position. They're quicker to deliver, and they can give you a really nice dose distribution. So you'll see a lot of those probably during your rotation in radiation oncology. So this is a kind of a visual. I can get it running. Hold on. This is a visual attempt at showing the dose buildup as the gantry rotates around the patient axis. Notice on the right-hand side image, the accumulation of dose gradually is demonstrated in white. The treatment is termed an ARC technique, and it is a common treatment for centralized tumors such as a prostate. So the gantry is rotating around, and then on the right-hand side, the dose buildup, is fully effect after one full arc of the gantry. So this image is what we see, we call it as a digitally reconstructed radiograph, or a DRR. It demonstrates what a beam would look like in relationship to the patient's anatomy. If you look at the bottom right-hand side of the screen, there's this little green body. That's a quick visual of how the patient is on the treatment table and how the treatment machine or the gantry is oriented to that patient. So this is actually an image that is from the planning computer, and it really helps the dosimetrist, have a visual of where the gantry is in relationship to the patient. The DRR image is part of the planning process, and the beam is placed, in this case, near the target. which is the red outline. And the treated area is the yellow outline, which is about 2 centimeters beyond the target. The blue lines, they're referred to as multi-leaf collimators, or MLCs, and they represent miniature leaves that conform to shapes determined by the dosimetrist. In this picture, there's about a 2 centimeter margin between the MLCs and the red target volume. Margin is necessary in order to get an adequate dose to the target without compromising, dose beyond that. So what you need to be aware of is that you would have margin beyond the target. So you wouldn't have the MLCs just come right up to the target, because you wouldn't get enough adequate dose to the target. So you need to have space around it. And a term is a PTV is what typically we define as the planning target volume, which is a margin around the actual tumor. So you'll hear that a lot in the rotation. So margin is necessary in order to get adequate dose to the target. So once again, the MLC leaves are spaced beyond what's contoured in as the tumor. Notice now that there's kidneys outlined also in this image. The MLCs help to block out most of those kidneys, which thereby minimizes the radiation dose that they should receive. Blue leaves in this image are actually solid in the treatment machine, and they restrict the radiation from passing through it. So here's an image of a picture of what the MLCs would look like in the head of the treatment machine. So they can adjust and change shape depending upon if it's in a dynamic motion, or they can be static, as you see in this image here. Now we're going to look at some of the basic treatment fields and some of the more simple treatment plans as well. And this one in particular is cancer in the vocal cord area. So in early stage vocal cords, like this case, could be treated with opposed lateral fields. You don't need to have blocking or none of the MLCs, because it's generally a square or a rectangle field. In this image, the lines displayed are termed isodose lines. So those different colors, the red, the orange, the blue, the yellow, the green, those are all isodose lines representing different dose levels. So in the upper left-hand side, you'll see some numbers, 100, 97, 94, 90, and those correlate with the color of the isodose line, and that's a percentage of the dose. So this plan is really not that good, because the 100% line is very anterior. It's it doesn't encompass all of the target volume. So we strive for a more uniform dose distribution, and in this case, we're not getting that. However, we can improve the plan by utilizing wedges in the pathway of the beam, and the wedges are going to help compensate for the patient's body contour. So in this case, the wedge is oriented with a thick end anterior to compensate for the thin area of the patient's neck. Compensators like wedges help improve the dose distribution, making it more uniform around the target volume. So you can see the orange line here is much improved over the prior image that we saw, and even the red is much more, it's not encompassing the entire target volume, but it's very close to it. So this is very common of what you'd see in a true vocal cord cancer. Now we're going to look at another treatment planning concept, and that involves the internal organ motion. In this case, the left breast is the treatment area, but the heart can oftentimes fall within the area of the field. This is seen in the image on the right, where the heart structure in red falls inside the yellow treatment field outline. If if the patient is able to take in and hold a deep inspiration, the breast will move away from the heart and spare it from receiving a high dose. This is demonstrated in the image on the left. It's a very common technique when we are treating left breast cancer. Dose distribution displaying this breath hold technique is seen on the left-hand side of the left side image, and then on the right is the free breathing. So as you could see that the breath hold technique will keep the heart out of the treatment field on the left-hand side, thereby reducing the dose that the heart receives. If the patient is free breathing, their heart is going to be in and out of the treatment field and receiving more dose. So now we're going to look at the prostate planning using some of the more advanced tools. In prostate cancer, we typically use a term called volumetric modulated arc therapy, or a VMAT. And in this case, the gantry is rotating around the patient when it treats, and those MLC leaves are moving to conform to the target and spare any OARs that might be within the pathway of the beam. So we're going to start by just looking at the normal contour structures that are done. And again, femoral heads, the bladder, the rectum, the penile bulb, small bowel is commonly also contoured in, but it's not demonstrated in this image. The target would be the structure in red, that's the prostate, and then the blue is the PTV, or the planning target volume, which is the expansion of the target. So again, giving the target a little bit of room around it. So beams then are placed over the target volume, and in this case, there'll be an arc, which will be a 360-degree rotation. So the patient will be laying, still on the table, and the gantry will rotate around the patient. It's very common for prostate cancer treatments, and again, it's called VMAT. So once the contours are in and the beam is placed, then we have to run an optimization on the treatment planning computer. So the dosimetrist puts in the target dose goals, and those were defined by the radiation oncologist, and then also dose constraint values that adhere to the physician's prescription, and also publicized dose tolerance tables. The computer then will try and meet these dose constraints and target objectives by creating the best plan achievable given the limitations of those constraints. Once the computer has gone through its iterations, the plan will be assessed by the dosimetrist, and we might need to rerun a couple plans to get the best possible. So in this case, you go through one iteration and do a calculation, and then assess the plan. And if it's not good enough, maybe it's not adhering to the rectal constraint, and we have to go back and change the values that these objectives are given initially and try to improve on it. So we'll continue to do that until we can find a plan that we think is going to be sufficient for treatment. Some of the ways that we evaluate the plan are using this tool called the dose volume histogram, or better known as the DVH. The DVH is used to provide information about how much dose the contoured structures receive. Organs have radiation dose limits which correlate to their function. If an organ or structure isn't contoured in the beginning of the planning process, then there's no way to evaluate accurately and see what dose it's going to be receiving after we've gone through a treatment plan. So if you look down at there's the different structures, bladder, body, femurs, penile bulb, and the rectum. There's also color codes that are related to those, and then they're also then demonstrated on the graph. There's the maximum dose that you can be determined after the calculation's done, the mean dose, the min dose, and then we can also see volume. So, like for instance, the rectum, if you were to look at what 20 gray is, which is this bottom values down here, 20 gray receives about just under 60%. The target volume is up here in the red, so 100% of the target is getting 50 gray, and that would be, that would be our prescription dose. The rectum and the bladder, both the pink and the brown, are actually going beyond the prescription dose, and that's because they're overlapping into that area. So there's no way to avoid that, and if we tried to reserve their dose to less than 50 gray, then we would be underdosing our target. So there's the challenges in finding the right balance between, how much compromise you have to give. And that also becomes the call of the radiation oncologist as well. So once the dosimetrist has satisfied with the plan, they notify the radiation oncologist that it is ready for review. The radiation oncologist uses many resources when approving and reviewing a plan. Some common tools will be just basic feedback from the dosimetrist. They'll want to know if it was, if there were any things that challenged it or, issues that they needed to be aware of. But also they're going to be assessing the DVH, the isodose line display, and also the published dose constraint and objective guidelines that are available to the physicians and people in our field. Once the radiation oncologist is satisfied with the treatment plan, then dosimetry will print it and notify physics to proceed with the plan QA. So in summary, dosimetrists follow guidelines provided by the radiation oncologist and medical physicist. The treatment plan goal is always to deliver the prescription dose to the target and limit dose to the surrounding normal tissue as best as possible. We have the radiation oncologist review and approve the plan before moving forward with the physics review. Dosimetry, the treatment plans coming from dosimetry must pass physics QA before they can be acceptable for treatment delivery. If the plan should not pass QA, the dosimetrist then is back to the drawing board to create a new plan. The radiation oncologist will have to re-review and approve it, and physics will then perform another QA on the revision. So overall, that's kind of a day in the workflow, or I guess a week in the Department of Radiation Oncology. Thank you so much, and I hope you enjoy your rotation. You're going to get some contouring practice, and I hope you enjoy it. Don't hesitate to ask a friendly dosimetrist for help. And take care. Thanks. Bye.